I'm Rachel Kuchtey. I am a professor in ophthalmology at Vanderbilt. It's really a great pleasure to moderate this session. What a great meeting. We had a great discussion, great presentation yesterday, all day long. And this morning, we just had the keynote and a great discussion. The whole panel offered so many insights from the research perspective, from the patient perspective. While I was listening, I was thinking, gee, would I lose my job as a physician and everything's gonna be solved by AI, even surgery? But one thing really I have to say is that we can use AI tool. It's just a tool to help us to diagnose glaucoma, to manage the patients properly and in the best way. But there's still human touch that AI cannot replace. I am in the room with the patient and someone comes to me with a narrow angle and I'm gonna tell that patient, I'm gonna take out your cataract, I'm gonna make you see better, I'm gonna cure your glaucoma. And that's just the joy in the room, just two of us, and just really nothing can replace that. And it's not uncommon. I am the bad person. Patients come to me for the third, fourth opinion. I'm the one who has to deliver the bad news. I made a big football player cry in my room. And it's, that patient sticks with me for, as a fourth, fifth opinion and becomes we grow old together simply just because I put my hands in his hand and we cried together. So this is something I don't think AI is gonna replace. So I think, the yesterday to this morning, just so powerful. I am so grateful to the foundation that give us this platform to bring everyone together rather than in a silo. The researchers, the physicians, the most important thing is patients. That's why you're here. I was just told we have over 40 patients registered for this session. So I am so excited. I think it's going to be very powerful. With that, let me introduce our first speaker, Dr. Aakriti Shukla, who is Leonard Lauder, assistant professor at Columbia, is the Lauder professor, the one who just passed away a couple weeks ago in his 90s. Aki is like me, is a glaucoma specialist. She's a clinician scientist. Her research interest is in the outcome of a surgery, early detection of glaucoma progression. And she is very passionate in global health initiatives and has done much work in many countries. And she is on the editorial board of ophthalmology glaucoma. She's also on the medical advisory board for this foundation. She's a great speaker. I've heard her talk about different topics in the different settings. And today she's going to talk about the glaucoma coaching. And thank you, Aki.
Thank you, Rachel, for that very nice introduction. And really thank you to the Glaucoma Foundation for everything that you're doing in advancing patient care and research for our glaucoma patients. It's really been a pleasure to be in this room and to learn from all of you. And I'm excited for our upcoming discussion on impacts to patients. So today, now we'll be shifting gears a little bit from AI to glaucoma coaching, but you'll see over the course of the presentation that we will revisit AI because it is kind of out everywhere. I'll be starting here with the physician's perspective, and then soon you'll hear from our lovely patients. Here are my financial disclosures, none of which are relevant to this topic. The concept of health coaching. I'd like a show of hands in this room. How many of you have received or offered coaching in medicine or health? Raise hands. This panel probably, since they are experts in coaching, but you'll be surprised at how much of this resonates with you. These are conversations you've had with your patients in the office, or if you're a patient yourself, these are things that you have talked about with your doctors, at least hopefully to some extent. And here you can see some of these medical journals that are very prominent are publishing more and more on health coaching in various settings. In fact, if you do a PubMed search, you'll see that this topic has really skyrocketed in interest. Almost 40,000 results appear when you search coaching, and there's broad interest across specialties, including weight loss, cardiology, endocrinology, primary care, and so forth. This is a term that really originated from professional sports coaching, where the athletes' goals were aligned with their practices. And you'll see that as a glaucoma patient, that sometimes you do sort of feel like an athlete in that you're constantly having to take care of your health multiple times a day. And we'll talk more about that. If we look into glaucoma coaching on PubMed, there really aren't that many results. And this is an area that can be explored much more. We'll talk about the available literature, as well as all of the work that is being done in glaucoma offices every day. So what is health coaching? This is a patient-centered method used to help individuals develop and improve their health management skills. The idea is to align the vision of optimal health with health-oriented goals, improve understanding of conditions, especially conditions that are so nebulous and have definitions that are so widely refuted, even by their experts, as you guys have all seen today, reinforcing positive behavioral changes and improving clinical outcomes. Importantly, glaucoma health coaching will be distinct from the very traditional physician-patient interaction in which a physician prescribes a treatment to a patient, and it's just a one-sided sort of interaction. The patient passively accepts it. So why is glaucoma coaching important? As we know, glaucoma is a chronic condition. It's often asymptomatic, especially in the beginning. And patients will tell you every day that there is a need for improved patient understanding and engagement. Glaucoma has high rates of non-adherence and poor follow-up. And this is seen across the medical specialties. It's not really limited just to glaucoma. 30 to 70% of individuals with chronic conditions adhere to medication, and about 50% discontinue medications within the first month that they're prescribed. Medication adherence in glaucoma is very similar to elsewhere. It ranges anywhere from 5% to 80%, depending on the study. Just some more background on adherence. Adherence to prostaglandins, which is typically the first-line medication for glaucoma, tends to be better than other medication classes, but the addition of a second medication lowers adherence to the first medication based on pharmacy refill data. So some of you as patients may have had this experience. You know, you're probably, if you're prescribed a medicine, prescribed latanoprost, bimatoprost, and so forth, and then maybe you needed a second medication, and then you found it more difficult to use even the first medication that you were prescribed. And often, patients overestimate their adherence. In this study, they were monitored with a microchip electronic monitor. Patients self-reported 100% adherence. Doctor, I'm always religious with my eye drops. But the electronic monitor found that adherence was really more like 76%. And this is a study where patients knew they were being watched and maybe experienced some Hawthorne effect in that they ended up using their medications more often because they knew that the results would be available to everyone. So why is this the case? There's been a lot of work on this, and some studies, including these, have identified various factors that may lead to poor adherence. The top study noted here actually categorized these factors into various categories, including patient-related factors, regimen-related factors, the complexity of the regimen, the cost, the side effect profile, environmental factors, including lack of support, as well as provider-related factors, things that we are doing wrong, including poor communication, poorly explaining medication use. Generally, there's also lack of education regarding glaucoma, lack of effectiveness of eye drops, and problems with eye drop administration, forgetfulness, as well as some practical issues. There are a few fields in medicine where we ask patients to apply a topical treatment to any given body part multiple times a day for the rest of your life. And so there's no surprise that adherence is difficult. While adherence is a pretty complex topic, its outcomes are, as one would expect, pretty simple. In this publication from the Collaborative Initial Glaucoma Treatment Study, we're looking at self-reported adherence to glaucoma medications. And it was found that patients who reported never missing a dose of their medication had an average predicted mean deviation or visual field loss over 8 years that was equivalent to age-related decline. So they did just about as well as anyone who did not have glaucoma. Whereas folks who reported missing a third of their doses, a half of their doses, or 2/3 of their doses had more precipitous visual field decline that really aligned with how much of the doses they were missing. So poor adherence is associated with worse visual field and glaucoma outcomes. If that doesn't convince you that adherence to medication is important, even the WHO has said that the effectiveness of adherence interventions may actually be more impactful than any specific improvement or new medical treatments. So adherence, we know, is linked to physician-patient communication, which we know is less than ideal. In this study that videotaped physician-patient visits, it was found that visits were an average of 8 minutes. Does that align with what you've seen as patients? And during those visits, physicians did most of the talking. For about 6 of the 8 minutes, physicians were yapping away. And most of the time, these questions that physicians asked were really closed-ended questions. And physicians didn't really have the chance to get to know their patients or identify those who were missing medications. In fact, they were only able to identify 3 of the 13 patients who missed medications. So we were not asking the right questions. And another study found that patients who really engage in their care tend to do the best in terms of adherence. So physicians or patients who were entirely doctor dependent, they said that they relied on their doctor for all information about glaucoma, were less likely to have an adequate supply of medications. This study just demonstrates, along with many others, that patient engagement really is very important in order to have a two-way exchange and for patients to really be able to adhere to their treatment. So what are some approaches to physician-patient communication? You will have seen many of these. Number 1, not addressing the topic. This is quite common, but also ineffective. If you just ignore the idea of adherence and what the patient does once they leave your office, that's not going to really lead to good outcomes. Scripted approaches, these are also pretty ineffective. There's no one-size-fits-all approach for our patient care because, as we know, glaucoma affects a wide range of people, both in terms of age, demographics, personalities, etc. Motivational interviewing is an individualized counseling intervention that has shown improved adherence and health outcomes in other chronic diseases, and we'll talk a little bit about what its applications to glaucoma may be. So let's go into this a little bit more. It's a collaborative, patient-centered style of counseling. Excuse me. It engages patients by discussing priorities and obstacles to facilitate intrinsic motivation to change health behavior. So really finding something within the patient to get them to change how they might be carrying out their glaucoma practices. And individuals must develop personally compelling reasons to motivate this change. Self-motivation in motivational interviewing hinges on relatedness. So the counselor, whether it be a physician, technician, or other extender, must express empathy during counseling. Autonomy. The counselor must help the person overcome ambivalence, identify their own values and goals for managing the disease, as well as competence. The counselor must equip the patient with the knowledge and skills to work through barriers, implement routines to actuate this change. There's some core skills that are important in motivational interviewing, and the physicians in the room more than likely do all of these practices. I'll share here some specific phrases that the patients may have heard and us physicians may use. If you haven't heard these phrases, that might be an issue. You may want to consider changing your glaucoma specialist. Some of these include, can you tell me what concerns you have about your eye condition? What has your experience been like using your eye drops each day? And how do you see glaucoma affecting your daily life or future? Importantly, none of these are yes or no questions. They involve the patient really bringing out their own experience. It's important for the counselor to affirm what's happening. And this part of this includes kind of repeating what the patient is saying. It's great you've been taking your drops regularly. That takes some real commitment. I appreciate how much you care about preserving your vision. You're doing a lot to take care of your health, and that's not easy. Reflection. It sounds like you're worried that even with treatment, things could get worse. This is a comment that patients make to me almost daily in the office. You're feeling frustrated because the drops are hard to remember, but remember, you want to stay on track. And so you're saying that while you know the treatment's important, the side effects have made it challenging. So really trying to teach back and repeat what the patient may have said to you. I think this helps me better understand what the patient is saying, and oftentimes the patient corrects me a little bit. Well, I said this way, but actually I meant this. Next, it's important to summarize. Let me see if I've got this. You understand the importance of taking the medication, but you've been trying to take it daily, but you're finding it hard to remember it and to take it in the evenings. You're also unsure if it's really helping. Is that right? We've talked about your concerns about side effects, the challenges with your schedule, and your desire to keep your vision stable. These are all really important. And finally, it's important to obtain permission to provide information and advice. Let the patient open the door for you, so, important to know if you're welcome. Would it be okay if I shared some strategies that have helped other patients remember their drops? Can I offer some information about how this medication works and what to expect? And would you be open to hearing some options about managing the side effects you've mentioned? These are all kind of common conversations that we have with our patients in our office. Of course, this is a huge number of questions, and in the average 8-minute visit, not all of these may be discussed. But it's important to provide some of these questions in every visit and over time develop a longer relationship with your patient. It's also possible that these questions may not be best asked by the physician, and perhaps there's a physician extender or glaucoma coach who may be better suited to do this. Let's talk about that a little bit more. There have been previous trials on glaucoma adherence support. The first trial here had tailored automated phone calls and printed materials for glaucoma education. This was compared to usual care. It was found there was no difference between the groups that received this enhanced care versus the usual care, but both groups had improved self-reported adherence. This may be partially because the patients knew that they were in the study and they wanted to report some sort of improvement. But it may also be that patients do better once they know that the doctor actually cares about their adherence. This study at the bottom included a licensed clinical psychologist to deliver a 1-hour motivational interviewing-based counseling session, as well as culturally tailored glaucoma education and 3 weekly follow-up phone calls versus usual care. And in this particular study that used electronically monitored adherence, they actually did see an improvement in the group that received the glaucoma coaching. Now we're going to engage in a case study of a very important study that's going on at University of Michigan called the Support Education Empower Personalized Glaucoma Coaching Study, or the SEA study. This is a project that has been led by Paula Ann Newman-Casey, and I'll do my best in summarizing it here. It's a 7-month intervention, and in this study, the various program components included automated medication reminders for patients, 3 in-person coaching sessions with a technician or health educator who was specifically trained as a glaucoma coach, as well as 5 between-session check-in phone calls. Adherence was monitored electronically over the 7-month intervention period, as well as a 12-month follow-up period, and we'll discuss both of the results. Importantly, these were all patients who were monitored over a 3-month baseline period, and only those who had a median adherence of less than or equal to 80% were enrolled in this program. These were people who were not really doing well in taking their medications. They also self-reported poor adherence. And the main outcome was looking at change in electronically monitored medication adherence over time. So what did this program include? And is this something that we can integrate into our own practices? They had 3 glaucoma coaches, including a glaucoma technician, a health educator, and a social worker. Note, none of these were physicians, but we can probably take some of their approaches and integrate them into our own care. And all 3 of these individuals completed a 16-hour glaucoma-specific motivational interviewing program. For patients with poor baseline adherence, the glaucoma coach set up medication reminders that lit up or sent an audible alert when a dose of medication was needed. And if a participant was more than 1 hour late, they could elect to receive an automated phone call or text reminder. Isn't that nice? And participants could elect to receive any of these, all of them, or none of these reminders. And during the first in-person coaching session, the glaucoma coach actually used a web-based app to generate tailored glaucoma education materials, taught eye drop installation, which really seems like the right thing to do for our glaucoma patients. Many of us hand out brochures from the AAO, from TGF, and elsewhere, but these were materials that were really tailored to that specific patient. And this app also helped them generate AI-based counseling prompts to really guide the conversation. And in this first session, they identified barriers to adherence, used the person's strengths and motivations to guide potential solutions. The coach helped the patient put together a list of questions to ask the doctor at the next appointment, which, as we all know, these appointments are very brief, so it's nice for patients to be prepared with questions. And they also helped create an action plan of next steps to integrate the medication use into the participant's daily routine, because ultimately they were looking for improved adherence. The second session took place 2 months later, reinforced everything that was learned in the first session, as well as discussing motivation to take care of vision, how to leverage strengths, and practice instilling eye drops. They also went over the daily routine for eye drop use. The third session took place 2 months later, and so now we're 4 months into this 7-month intervention. And again, kind of reinforced what was said at the first session, discuss what part of the personalized glaucoma education content they wanted to review, and discuss any new barriers. There were also intermittent check-in phone calls, and these tailor the conversation to the participant's current level of adherence, focus on resolving issues. And importantly, these glaucoma coaches also updated the clinicians on adherence status based on via the AMR, and the clinician could decide whether or not they wanted to address it during the actual patient visits. So what were the results of this intervention? Medication adherence actually improved. So at baseline, these folks were adhering to medications about 60% of the time. After the intervention, they were adhering about 81% of the time. 95% of the group showed an improvement in adherence, and 59% showed an adherence of greater than 80% upon completing this program. So people really did improve over time. There was also an interesting dose-dependent effect. Each time the glaucoma coach met with the participant, adherence scores went up by a mean of about 2%. And so each one of these interactions did really help the patient. And overall, participants reported excellent satisfaction with the overall program. What happened after the intervention had concluded? So this group went back to check on these folks 1 year after the conclusion of the program. There had been no contact between the study team and participants in the 12-month period following the program cessation. And mean adherence at the 1-year time point was 67%, which is better than baseline, which was 60%, but lower than adherence during the program, which was around 81%. The authors concluded that intermittent reinforcement sessions may be necessary to keep up that high level of adherence and patient engagement. There are a lot of shortcomings of studying coaching and performing coaching. Number one, I think this is the biggest barrier to all of us, and maybe we'll discuss this more as physicians later on in the session, is that it's a very resource-intensive practice. Not many of us have 3 glaucoma coaches within our clinics who can, hold a total of 7 sessions with participants over a 7-month period. Many of us are trying to manage patients in the short time, the average of 8 minutes that we are seeing patients for. And then the shortcomings of studying coaching, well, of course, these studies have small sample sizes, there's a short duration of follow-up, patients may be more adherent because they know they're being watched. But as the authors of the C study concluded, booster sessions are probably important to allow for durability of the intervention. Looking at resource-intensive practices, of course, the in-person stuff is that way, but can AI play a role in glaucoma coaching? AI chatbots have demonstrated the ability to respond to questions about glaucoma management. There are a few published studies about this, and maybe folks in the room can also tell us about whether or not they've tried to engage with ChatGPT or other chatbots to help them navigate their glaucoma. And we know that AI can provide us scalability and accessibility, and most clinics are not really set up to do that. And interestingly, patients have also reported feeling less, quote unquote, judged during interactions with chatbots, and they may be more likely to disclose sensitive information to chatbots. This could potentially complement in-person care, especially if one has modest resources. In this study performed by Sally Baxter, they did something very interesting. They tried to use ChatGPT as a motivational interviewer. And you can see her prompt. It was using motivational interviewing techniques, ask me questions to, number one, elicit information about my behavior. Number two, identify motivations for change and or reluctance. And number three, develop a plan for change. Ask the questions one at a time. Let me respond. Be concise in your responses and aim for a 1-to-1 ratio of talking and listening. I am a glaucoma patient having trouble adhering to my medication regimen. And you'll see here that ChatGPT has a very nice conversation with this fictional glaucoma patient that's actually quite lengthy and helpful. So is AI the answer for glaucoma coaching? Well, there are potential issues here. Number one, safety and privacy. Not all of us want to give out our information to these chatbots. And importantly, there are factual inaccuracies or hallucinations. The chatbot often wants to make you happy and to please the user. So in this particular input that Sally provided, the patient said, I could try taking all my drops 3 times in the morning, so I don't have to remember to take them at night. Of course, that would be convenient. Any physician would say, well, that's not the best idea. The drops wane in effect over time. You need to space it out. But the chatbot happily responded, that's an interesting approach. Taking all your glaucoma drops in the morning could indeed simplify your medication routine, reduce the need for remembering to take multiple doses during the day. We all know this is a hallucination or inaccuracy, not the right way to proceed. And there is some concern that there could be worsening of disparities that we already know exist so much in medicine. If folks who are marginalized or people with poor insurance or no insurance are referred to AI-based care, and the people with the good insurance get real in-person care. That's obviously not appropriate. There needs to be domain-specific training to ensure accuracy and completeness of chatbot responses, and physician guardrails, as always, are important in this AI application to medicine, as in all AI applications to medicine. In looking at coaching, I think it would be short-sighted to look at just the results of the main outcome measure. Is adherence better after the coaching intervention? Coaching really benefits the patient in intangible ways, which we'll hear more about today. For instance, 97% of C participants mentioned that the importance of the glaucoma coach in improving their adherence. However, only 72% of them mentioned that medication alerts and reminders improve their adherence. So they felt like the interaction with the coach was much more important than the alerts they got. They overall felt like their communication with staff improved at the office also. And so even if the intervention does not significantly boost adherence, patients are more satisfied with their care, and all of the trials that have measured patient satisfaction demonstrate this. So I wanted to help us transition to the next segment, which will be mostly our wonderful patients talking, by getting the perspective of a Glaucoma Foundation board member, Mitch Hill, who happens to be here with us. He was very generous with his time and had a nice conversation with me about his experience with glaucoma coaching.
Well, I was diagnosed in 2017, and for the first 3 to 4 years of my glaucoma care, I was seeing a physician who was very busy seeing patients. And when I would have questions, but he was also always very busy and he had to move on to the next patient. I guess when I first went to her, I was expecting a little bit more of the same in terms of talking about, oh, let's do this with your eye drops and see you later. And she didn't really give me that choice. She said, hey, we're going to approach this in a real holistic manner. And so here's what I'm expecting from you. Or even though I've made all those changes, she's still asking me, so what more could we be doing? Tell me of any concerns you have. Let's talk about your situation. And she always kind of has the time to be open to discussing different ideas. Actually, Dr. Resnick tells me about many of her patients, some who are older, some who are forgetful, whatever the case might be, who do not adhere to their treatment path and their vision is continuing to deteriorate. And she said for a lot of patients, it's really something that they allow this to happen to themselves. And so you have a choice to make in terms of whether you can try to preserve the vision that you still have. And I take that, very seriously in terms of trying to adhere to my treatment plan.
And Mitch will talk a bit more later, but he wanted to share this very individualized treatment plan that he came up with his physician, and something that's really helped him engage in his care more. So in summary, glaucoma coaching is very important, and there is an unmet need for patient engagement, and overall adherence is poor. And there's a lot of work for us to do as glaucoma specialists in this area. Thanks very much, and I'll move on to the other part of our panel.